And we are recording.
Okay, well, welcome everyone. I am Dr. Donna Emanuel, and I am very happy to be here with you today to celebrate Bethany Thrasher as she presents her DMP project to all of you in the audience. Bethany is an outstanding individual, has made important strides in her ongoing scholarly journey at Western University of Health Sciences, and I could not be more proud to introduce you to all of her today as she unfolds her very most meaningful and productive work in the area of mental health stigma. So with that, congratulations to you, Bethany. You have reached a milestone in your professional growth and development with the College of Graduate Nursing, and I look forward to hearing your presentation. Bethany?
Thank you, Dr. Emanuel, for your kind introduction. Welcome, and thank you to everyone who were so gracious to give your time today and join this session to learn more about my DNP scholarly project titled Implementation of the National Alliance on Mental Illness in Our Own Voice, Educational Intervention on Stigma Attitudes Regarding Illness in a College Setting. The purpose of this scholarly project is to implement and evaluate the effectiveness of an educational intervention on stigma attitudes about mental illness in a college setting. The aims for this project were twofold. The first aim was to implement the In Our Own Voice anti-stigma presentation to reduce stigma surrounding mental illness and normalize college students' conversations about mental health. The second aim was to increase college students' use of mental health support services and resources offered by the university. I'd like to provide this overview to bring light to what prompted the launch of this quality improvement project. It is understood that college students experience varying degrees of transitional stress while balancing competing priorities. And I know there's some college students on this call today. However, the stigma of mental illness acts as a barrier to help seeking, and access to mental health support services can assist in developing coping skills to manage the resulting stress. At American University of Health Sciences, the university counselor reported that less than 2% of the student body had sought out resources or free counseling services over the first 12 months offered. The lack of students accessing resources was concerning and showed a potential gap in help-seeking behaviors. The university faculty reported that many of their students seeking personal emotional support displayed signs of distress while sharing crucial concerns about the burden of college and other family stressors. These findings triggered the development of this quality improvement project. Finally, the global of disease is amplified by the mental health issues related to a myriad of factors, and the healthcare system is in dire need of future mental health providers to serve this rising need in mental health issues. And stigma is a barrier to individuals selecting this career path. There is a lack of understanding as to why college students with mental health disorders are reluctant to use university counseling services, and the impact that a contact-based education would have on college students' stigmatizing attitudes about mental illness. The purpose of this quality improvement project is to implement and evaluate the effectiveness of an educational intervention on stigma attitudes regarding mental illness in a college setting. The project intervention is a product of the National Alliance on Mental Illness, NAMI, which you'll hear me refer to frequently, the In Our Own Voice presentation for stigma reduction. I'll share more about this in a little bit. Every study should begin with a clear practice question, the PICO, as we've all been taught over the last couple of years and then beyond. The evidence-based practice question for this QI project is, among college students who are at risk for mental illness, that's our population, how effective is the NAMI, in our own voice, stigma reduction program, that's our intervention, in bringing about change in attitudes and knowledge surrounding mental illness as compared to attitudes and knowledge before the program. So those are our comparison and outcomes. The significance of the issue surrounding mental health is world known. The World Health Organization estimates that depression will be the #1 burden of disease globally by 2030. With the global pandemic in full force right now, there's little doubt about this estimate. The Healthy People 2020 initiative in the US has been focused on the priority issue of mental health for several decades. Yet, we continue to see the prevalence of mental health disorders rise. In the United States, mental illness is a priority concern for adults 18 to 24. With 75% of all mental illness presenting by age 24 years, it is extremely concerning to know that only 64% of college students who are in that age range who are experiencing mental health events seek treatment. There's a gap here. It's critical to provide early identification and access to treatment for mental health care for college students. The stigma surrounding mental illness remains a profound barrier to functioning in everyday activities. The stigma of mental illness obstructs or acts as a barrier to help seeking. There are many facets to stigma and stereotyping that goes along with it. It's important to prepare college students as well as the faculty, staff, and healthcare providers that are working with them. The contact-based stigma reduction intervention is a proven method. I have a few key terms to define for you to help bring some things into a little bit more clarity. The National Institute of Mental Health defines any mental illness as a mental, behavioral, or emotional disorder. Any mental illness can vary in impact from no impairment at all to mild, moderate, or even a severe impairment. Now, the National Alliance on Mental Illness, NAMI, which you'll continue to hear me refer to, established in 1979, is the United States' largest grassroots organization working to improve the lives of those affected by mental illness. And presently, NAMI has over 500 US affiliates. The World Health Organization defines mental well-being as a fundamental component of one's health. Mental health is defined as a state of well-being in which an individual realizes their own abilities, can cope with the normal stresses of life, can work productively, and is able to make a contribution to their community. Stigma is multifaceted, and it's noted to be present with the co-occurrence of its many components. Those components are labeling, stereotyping, separation, status loss, and discrimination, and further indications that for stigmatization to occur, power must be exercised. This figure from the World Health Organization provides a visual of the contributing factors to mental health and well-being. As noted in the definition of mental health, we know that mental health or psychological well-being is influenced not only by an individual's characteristics or attributes, but also by the socioeconomic circumstances in which a person finds themselves and the broader environment in which they live. So we like to talk about that in terms of where we live, work, learn, and play. These determinants of health are different for each person. The theoretical framework for my practice project is the stress vulnerability model. And that is a framework that comes from the psychiatric professional field. Dr. Joseph Zubin conceptualized this model in 1977. It helps us better understand the relationship between external stressors and internal stressors, which are the main triggers for a mental health event. Vulnerability is a predisposition or susceptibility for higher rates of physical, social, and mental health issues, including an individual's morbidity and mortality rates. The stress vulnerability model was applied to better understand the focus of and the function of stress on college students and the potential for relapse. Subsequently, the stress vulnerability model draws attention to the fact that those with and at risk for mental illness face adverse psychological impacts at higher rates when faced with external stressors. And you can see in the model here, biological stressors are those internal or intrinsic vulnerabilities, while life crisis, substance abuse, interpersonal work stress, and in this case, college stress, are the psychological stressors, or psychosocial stressors. Symptoms of mental illness surface in three different main ways, which we see: anxiety, depression, and psychosis. I wanted to share this graph showing the relationship between the stress of a challenging event, which you can see on the left-hand axis, and the ability of coping skills one needs to maintain mental health. The threshold point is where we might see symptoms like anxiety, depression, or psychosis, which is errors in thinking, ruminating, or overthinking. It's noted on the slope of the graph. As long as the balance of stress or challenging event remains within the area, if you see below the slope, wellness, there are no mental health issues. If the stress becomes too great, the level of vulnerability rises for the individual to an intolerable level, thus triggering a mental health event. The ability for an individual to manage with coping skills is a factor in avoiding the negative impacts on one's physical, mental, or emotional health. And I want to assure you that are in the audience that don't have a great deal of experience with mental health care, that while stress alone does not cause a mental illness, the readiness of an individual to respond to a life stressor with the appropriate coping methods is a critical determinant for success in managing those stresses. And in the case of our QI project, we are focused on the transitional stress of college life. In the review of the literature, I began that relevant search in February of 2019 and concluded in February 2020 using the following methods, utilizing databases such as the Academic Elite, CENAL, PubMed, as well as additional literature identified while completing the DNP coursework using the Pomerantz Library at Western University. There were some additional websites that are noted there. The search was focused on a 5-year window of full text articles in English language from peer-reviewed journals, addressing research focused on college students and the stigma of mental illness or mental health disorders. The search was limited to adults 18 to 64, since college students fall within that age range, and that's our population of interest. Articles that did not meet the inclusion parameters of targeting college students and the stigma of mental health, or those studies that reused data samples from previous studies, were excluded. The key terms used in the search were in various combinations and included mental disorders and college and students and social stigma, social and stigma, social stigma and stigma, a lot of variations of those terms. 3 themes emerged from the literature through this review. And one unplanned outcome was the identification of a germane survey tool to measure stigma in the population. And I'll share more about that a little bit later. The first theme was the stigma of mental illness. Harmful elements of stereotyping, prejudice, and discrimination, and the shame of stigma prevent a person's ability to reach their full potential. Levels of stigma are divided for our purposes in 3 different categories. Structural stigma encompasses policies, both private and public, that restrict opportunities of individuals or groups. And these restrictions may be intentional or unintentional. Public stigma, communities' acceptance of stereotyping, discrimination, and prejudice towards those with mental illness, is actually the level of stigma that we're targeting with this project. And finally, self-stigma is the negative self-limiting factors from accepting that public and structural stigma in terms of prejudice and discrimination on self. Again, barriers like stigma delay treatment and exacerbate a person's overall health. Second, we identified the college student as a vulnerable population. We know that role strain and transitional stress increase the risk of mental illness, and the first session of attendance in college can be extremely stressful, and the internal and external stressors have a significant impact during this time. And support to develop those coping skills that students may come into a program with, or to develop or to strengthen them or teach them, is very beneficial. College students tend to minimize their symptoms and often avoid disclosure of any mental health disorders. A 10-year study that concluded in 2017 had a very large population screening college students in terms of depression, found that 26.9% of the respondents indicated they suffered from depression, while 8.2% reported suicidal ideation. These figures are disturbing and demand that policymakers and academic leaders alike join arms to respond to this serious issue in their midst. And finally, treatment seeking at the college level across the United States was found to be increasing, causing a significant burden on counseling services and the providers within them. The final theme is the educational intervention or anti-stigma program. Outreach programs to reduce stigma must still be delivered by a trusted organization that has a proven track record of building mental health literacy. Mental health literacy and education must include signs and symptoms of mental illness, and the normalizing of conversations around mental health supports compliance with mental health treatments like medication and counseling services. Please take note that traditional psychiatric courses, like those required for a healthcare curriculum program, do not impact stigma positively. In fact, the literature reveals that increased stigma has surfaced after the psychiatric courses, and we see that as a major negative in the literature review. The knowledge gap can produce stigma that causes the prejudicial and discriminatory behaviors. And college students really truly benefit from a variety of methods that were uncovered in this literature search. The Johns Hopkins Nursing Evidence-Based Practice Model was used exclusively to appraise the literature. Levels of evidence are graded from 1 to 5, indicating the strength of the evidence, and A to C for the quality, high quality, good quality, low quality. One is easily able to group and grade literature efficiently using this literature assessment tool. For this quality improvement project, a total of 40 articles were abstracted with 20 chosen for inclusion. This table shows how the 20 articles were graded, and you see that most significant number of articles fell within the level 3, and the majority received an evidence score of A. There were no level 5 literature included in this study. The In Our Own Voice presentation from NAMI was delivered by trained facilitators with a lived experience. The Stigma Evaluation Survey tool, SES, was included and in a pre and post survey format. There are 20 survey items across the 3 subscales. The descriptive statistics that were collected from the participants in this study were the participant status, where they were a student or staff, age, gender, ethnicity, level of education, and prior contact with someone with a mental illness, such as a close friend or family member. The NAMI In Our Own Voice program is designed to support education and was actually developed from an Eli Lilly grant back in 1996. We utilized the 60-minute session version with 2 facilitators that appeared to be of college age. They looked very young, and that was on purpose to better connect with the college age audience. Sharing the speaking back and forth format between the 2 facilitators allowed them to share their personal stories. Every one of these In Our Own Voice presentations is exclusive and unique to the presenters and their experiences. They share the main 3 elements of what happened, what helps, and what now or what next for their life story. The virtual platform that was used for this project in response to the COVID-19 mandated social distancing was a new feature for the NAMI organization. And in fact, this QI project was the first implementation of In Our Own Voice in the virtual platform in an academic setting. The subscale that were included in the Stigma Evaluation Survey were stereotyped attributions, social distancing, and social responsibility. These 3 areas, I wanted to provide you with sample questions from the survey, and you'll see here that stereotyped attributions, which are that, a person with mental health disorder could have some control over their mental illness, whereas we wouldn't expect someone with diabetes to control their illness. So the sample item here that I shared with you is most people with a mental illness could snap out of it if they want to. A Likert scale 1 to 5, strongly disagree to strongly agree, were used for the responses in the survey. Social distance example would be, I would not want someone with a mental health disorder or mental illness to be a school teacher. So this is indicating the need to put more distance between oneself and someone with mental illness. And finally, the subscale social responsibility, I would sign a petition to support better programs for the mentally ill, indicates actually, if they say strongly agree, a positive. And that item there, if you'll see the asterisk, is a reverse coded item to we changed the number from 5 to 1 to indicate a lower level of stigma. So just to quickly elaborate, the stereotypical attribution stems from the attribution theory that people with mental illness have a hand in their illness or feeling of personal responsibility. And as I noted earlier, expressions of social distance refers to the willingness to be close to a person with mental illness. And finally, feelings of social responsibility shows a willingness to support people with mental illness with methods like donating time or money to mental health organizations. Don't worry, I'm not going to read this whole table to you. So this table represents the sample pre and post intervention. And the setting was the new student orientation is designed for nursing students preparing to enter the college core nursing program. Participants included in this study were nursing students, faculty, and staff, and the response rate pre-intervention was 84.7% and post-intervention of 88%. So you'll see that there's a total of 94 participants from the pre to post surveys, and we have a variety of statistics here, which I've highlighted some of those pieces for you so that you can see that 75% of the post respondents were female and 81.8% of the respondents were students. So this is what we've all come here to see. Was this quality improvement project effective? What does this table represent? Thank you for asking. So the measures of statistical difference, a t-test compares the means values from two samples. And in this case, it was independent groups because we did not pair the pre-sample to the post-sample because we had different numbers in respondents. With the 20 items and impact of reverse scoring on the negatively written items, the highest score possible in this survey is 60, representing the highest level of stigma results for the SES tool. The pre-intervention mean score for the group was 47.18 with a standard deviation of 8.9. Post-intervention, we're looking for a drop in overall mean scores. And for the group here, we see aggregate mean score dropped to 43.2 with the standard deviation of 6.99. Now, with the p-value set at or below 0.05, we know that this p-value of 0.019 indicates that there is a statistically significant change in the group's responses from pre to post. This means that the In Our Own Voice presentation had a positive impact on the group's stigma and reduced, we see that in the overall reduced score. And this is pretty incredible considering it's the first time that it's being presented in a virtual setting. Kudos to those facilitators. So I would like to share with you across the subscales, we compared the independent t-test samples. The scores decreased from pre to post implementation across all of the subscales, indicating that reduction in stigma, which it was statistically significant in the expressions of social distance. You can see here that the p value is 0.005, but do allow me to share with you and point out that if you look to the right, feelings of social responsibility, take a look at the pre-survey result, 2.18. It's actually the lowest of the subscales pre-intervention. Quite interesting. I wanted to kind of catalog the results for you into this table to give you a quick review of the numerous areas in which the statistically significant reduction was noted. So comparisons of the SES aggregate score sums and the mean scale scores pre and post for the groups. Out of the 7 demographic groups, we had 5 groups show significance in one or more subscale. The SES subscale expressions of social distance for female participants was very impactful with a p-value of 0.002, showing a significant drop and change. That is very meaningful in the fact that 75% of this group were female and they experienced a change. Participants with experience with mental illness experienced a drop in stigma, both in the expressions of social distance as well as the stereotyped attributions. So it's pretty exciting to see all that change. Now, although again, the feelings of social responsibility did not have any groups that had statistical significance, I just reviewed with you that that was the lowest pre-intervention score of all of them. So the scope of the quality improvement project includes stigma as it pertains to the public at large, but with an essential focus on college students who are enrolled in the health sciences program here at AUHS. Our goal with this quality improvement project was to impact all of the participants' overall stigma across all of the demographic groups. The social responsibility results indicate in my view, that healthcare professionals have an overall higher sense of social responsibility, which may be what draws them to a career in the healthcare field. So most of our students are actually all of the students in this particular sample and most of the participants all are serving in healthcare. Introducing new college students to the mental health services through an anti-stigma program has a significant impact. The integration of the In Our Own Voice presentation is easily coordinated with NAMI at the local level, and it's available across the country and now virtually at pretty much anywhere. And their streamlined online process makes it really seamless. All future college students should experience the In Our Own Voice presentation. Limitations of the project include using the virtual platform. There were some internet connectivity issues. Some of the audience participants had limited capacity with our capability with using the technology. Translation of the SES tool into an electronic format was a little limited by the DNP Scholar, but it did come together and everything was included. So it was very exciting. Implications for practice that I'd like to share with you, that the lowering of stigma and normalizing of conversations may improve overall health for college students and the staff that are serving them. We're looking at improving the attitudes towards people with mental illness, and I hope stimulating or inspiring those students to really look at a future career in serving the mental health population. In terms of project sustainability, the leadership at AUHS was quick to respond to this project from the very top, from the owners all the way down through the Student Services Department, as well as the School of Nursing. And the NAMI In Our Own Voice coordinator, the university counselor who's here on our call, I'm so grateful, and the Student Services team highly supported this project implementation from the start. NAMI now presents all of their In Our Own Voice presentations and other presentation projects virtually. And as I noted earlier, this was the first presentation in an academic setting, and I'm very proud of that fact. Oh, sorry, wrong way here. Future recommendations. The study designed uses one group and it provides a snapshot before after the intervention, and that could be carried through with a reassessment down the line. So we should consider reassessing at 12 months periods and at the close of the student's program to see if there was a long-term effect in the reduction of stigma. The other recommendation that I have is the consideration of a paired t-test method used in future orientations should the university determine that they want to continue to look at the impact of the intervention. Data should be collected at the University Counseling Center to follow up on how many students or what is the increase in students' utilization of resources and counseling services in order to further validate this process and implementation at new student orientation. There is a need at the university level for the stakeholders to continue to embrace the importance of reducing stigma around mental illness. And this would be nicely demonstrated by including the staff and the faculty in future In Our Own Voice presentations so that they can experience the benefits and the stigma reduction that results from that presentation. By understanding the factors that produce stigma in the college setting, institutions can improve the help-seeking behavior and enhance academic outcomes that will promote the mental health and well-being of college students. And The conclusions that I would like to share with you are the implementation of the contact-based intervention in our own voice was effective in meeting the program's primary aim. Contact-based educational interventions targeting stigma in higher education are essential in advancing sustainable processes to reduce stigma and improve mental health. We are able to validate the literature supporting the use of a contact-based intervention, like in our own voice. And our hope is that this QI project will support the university counselor, Corinne Humphreys, who has joined us here today to gain support in the implementation of the In Our Own Voice presentation in future orientations. The impact to stigma may increase college students' use of mental health resources, and this increased knowledge should reduce their stigma. My reflections. Ooh, okay, I'm going to try to hold it together. The DNP essentials are the benchmarks for what a DNP scholar should master by the close of their program. In reflection of the last 2 years and the courses that I've experienced through the Doctor of Nursing Practice program, I can say I have grown as an advanced practice nurse, as a nurse educator, and as an expert in population health. The DNP Essential 1, Scientific Underpinnings for Practice, was highly influential in the development of my understanding, insight, and advanced level competencies needed to serve the mental health population. The first essential focuses on the translational scientist's role and the critical skill needed to synthesize the evidence. Value was placed on working across the table with a variety of interprofessional communities to meet the needs of this population in a wide variety of practice settings. This QI project brought me into uncharted territory. Before the initiation of the QI project, I had very little formal professional experience in mental health or psychiatric nursing practice setting. This has changed tremendously over the 2 years due to Western University of Health Sciences first-year courses. Philosophy and Science and the population-based prevention courses, and the inspiring deep dive into the DNP project literature, I was able to take early field work and drive the Vulnerable Population Proposal Project, and this allowed me to investigate areas of science beyond nursing practice. Essential 6, interprofessional collaboration for improving patient and population health outcomes. Collaboration should have been my middle name rather than Anne, but you know, it's a family tradition. Today, more than ever, the healthcare systems are changing at all levels. And in order to meet the need of diverse populations, the DNP scholar needs to act as an authentic leader to use collaborative methods to work across the table with practice partners to meet those needs. I was given a precious opportunity to build this QI project with a team that was willing to transform the delivery of an evidence-based practice intervention with a focus on the population-centered care. The Quality Improvement Project utilizes the interprofessional practice partners to impact this vulnerable population, targeting the level of behavior change and ideas about lifestyle choices and attitudes to encourage or discourage the choices that people make to improve or decrease the limitations on their health is important in this particular essential. Through this journey, I have received the training, the vision, and the fuel and the grit necessary to overcome a myriad of population health concerns. When equipped with the right tools, resources, including an empowering and interprofessional team, I was able to drive this project to demonstrate that this collaboration was very beneficial. A wide array of stakeholders were needed, and I gained their support through this project. And I'm excited for this dissemination phase. The focus of this project was the gap in help seeking of mental health services by college students in a college setting. My references can be reached here at this QR, and I've allowed my references or my email for you to reach me later. Super quickly, I do plan to continue my dissemination with the American Public Health Association. I did stage 1 presentation of my project with them in May, and I plan to continue to share this work, and I hope that I have the opportunity to inspire others to carry it forward. And one day I hope to I hope to publish in a peer-reviewed journal. And finally, I would like to acknowledge some wonderful individuals who supported me through this scholarly journey. First, my clinical mentor, Corinne Humphreys. Thank you for being a counselor, my counselor, an encourager, and believing in this project and the good work that was within it. Dr. Chris McGladry, my team leader, thank you for your patience, kindness, and the intelligence in bringing me quickly into a level of readiness to tackle a project in an area outside of my nursing expertise. Dr. Donna Emanuel, you're my fearless leader of the DMPA, and the care that you have shown my cohort is a demonstration of your dedication to the art of nursing and your servant leadership. Thank you for modeling all of this for us. Miss Kelly Mons, your support was invaluable to me along this incredible journey, and I appreciate your Friday fill-ups. Only DNP students will know what I'm talking about. Dr. Mary Lopez and other CGN faculty, Dr. Hicks, Dr. Horowitz, Dr. Stone, Dr. Twasson, thank you so much for your patience and support along my journey. I have felt your care in every step. And finally, to my family and my friends and my peers, I want to thank you from the bottom of my heart. And last but not least, my sweet and supportive husband, who has earned his honorary doctorate and is my MVP. He has done a tremendous work to support me and endure this journey. And I have loved every minute of it. And I have loved and very much am grateful for his support. Thank you, everyone, for being here today, and sorry about my snafu, and I am open and willing to field any questions that you might have.
Well done,
Woo, great
Bethany.
job.
Yeah.
You did it.
Beautiful job, Bethany. Beautiful, as usual.
Thank you so
Yes.
much.
Bethany, this is Dr. Emanuel. Outstanding, phenomenal work. What a demonstration of what a DMP is and will continue to be. Your excellence in this area of mental health, looking at stigma and stereotype, and really doing the hard work behind the scenes, and gathering all sorts of wonderful collaborative practice partners. I salute you in your ongoing work and committed work in this area that is so crucially needed.
Just unplug it.
Absolutely outstanding, and I could not be more proud of you. Dr. Bethany Ann Thrasher, congratulations to you.
Thank you so much.
Go, Dr. Thrash.
Oh my gosh.
So Bethany,
Yes, ma'am.
I'm a little emotional, just like you are. So very proud. And somewhere along the way, fate intervened and allowed me to work over the last couple of years with just an outstanding group of scholars, and you count among those. I'm so proud of you. It has been a true pleasure to work with you. I value every minute that we spent together, and congratulations, Bethany. Dr. Bethany
Thank you very
Thrasher.
much for your presentation.
Thank you.
Like I said,
Do we have additional comments?
This is from Helen. Hi, Bethany.
Hi, Helen.
Congratulations, doctor. And I'm so proud of you. We've been communicating, and I know already what you have for people with mental illness. I can't wait for us to continue discussing where you will come in to do the great work of a doctor of nursing practice. You know, a scholar you are. Thank you, wonderful presentation. We need to break that stigma. We need people with mental illness to get help. When people have asthma, they have all kinds of medical conditions. They are not afraid to tell people they have, you know, those. They are not even afraid to take their inhaler when they are, you know, suffering from asthma attack in public. But when they have mental illness, they don't seek help. We need people like you. Thank you.
Thank you so much for bringing that forward. It is critical.
Hey, Bethany, you have 36 supportive comments in the chat, so I will send those to you later.
Thank you.
Congratulations, you did a fantastic job.
Thank you.
Yeah, and I just want to, we had the pleasure to work together as careers go at American University of Health Science. And I have to say that you are very inspiring. I just wanted to say I am going to be tapping in on you as a resource. All right. All right. Thank you.
Excellent. Thank you too. I can't wait.
Congratulations, Bethany. Great job.
Thank you, Dr. Terrell.
All right. I'm Sally. Well, you know who I am. So I'm with NAMI. And every time I come to these presentations, you surprise me. Like, another surprise is that the goal was to get these presentations as part of orientation for that college. Every time I show up, now you make me want to show up to everything that you speak at. So it is a pleasure to work with you, and congratulations, doctor.
Thank you, Sally, one of my college appearing facilitators for the In Our Own Voice Quality Improvement Project.
Well, simply wonderful, Bethany, simply wonderful. Are there any additional comments from our audience?
I just want to say congratulations, Dr. Thrasher. This is amazing. The project, just like anything I've known you to do, you did it. You did an amazing job.
Well, we certainly are proud of our Dr. Bethany Ann Thrasher at Western U and are looking forward to working with her, as all of you have mentioned. Are there any additional questions?
Not so much a question, and it's not exactly a scientific show of what this means, but following this project, we've actually had an increase in counseling requests at the university. So it is actually making a difference. So that is awesome. You have made a huge difference in that school. And Sally, you and I are going to have to collaborate to make sure that we keep this work going for them.
We do present a lot of colleges.
Hi, I like to also add, my name's Jacqueline, and Bethany, I'd really, Dr. Thrasher, I'd really like to add that it's very greatly admirable that you did bring a situation or this topic up, because as a college student, I was afraid that I didn't want to seek like anything that would help with mental health, because it does effectively work for a college student, because outside of studies, we do tend to get into stressors and then internal stressors that we come across while we're also studying, on top of living the life and kind of balancing things out. So I definitely do support your subject and your presentation, because it does absolutely work. And I'm really great. I'm really happy that you've presented your presentation. Thank you so much, Dr. Thrasher. You did great.
Thank you so much, Jackie.
once again, Dr. Thrasher, I congratulate you on just a beautiful job, wonderful scholarship. Yes, you should be smiling cheek to cheek. Well deserved, so beautifully presented. You are going to lead us leaps and bounds, and I know that this ongoing work of yours and your passion and your love will shine through, and we have much to learn from you in the future. Outstanding. Congratulations.
Thank you so much.
You're welcome, Bethany. Well deserved. So with that, I would like to conclude by saying thank you to everyone who joined us today for this most fabulous presentation. Thank you again, and congratulations once more to Dr. Bethany Ann Thrasher.
Congratulations.
Congratulations, Bethany.
Well,
Thank you everyone for joining us.
Congratulations.
Thank
So
you.
proud, Bethany, so proud.
Thank you so much.